Hello and welcome back. For those of you who don't know me, I'm Dr. George Cook-Rinn, a chiropractic neurologist specializing in neurorehabilitation with faculty affiliations across several chiropractic postgraduate programs. In these short clinical discussions, we take a close look at topics in brain and nervous system rehabilitation, the neuroscience behind them, how they present clinically, and what we can actually do about it. Today's topic is no exception, so let's get started. Progressive Balance Rehabilitation, a 3-tier learning protocol. Introduction. What you're seeing is a structured balance rehabilitation protocol built around 3 functional tiers of difficulty, namely Safe Harbor, Challenge, and Impossible Goal. These aren't just labels for how hard an exercise is. Each tier plays a distinct neurological role in driving cerebellar adaptation and motor learning. The protocol is grounded in research on how the brain learns complex motor tasks. A 2012 consensus paper on cerebellar function published in the journal Cerebellum by Manto and colleagues established that the cerebellum drives motor learning through prediction error signals. These are mismatches between what the nervous system expected to happen and what actually occurred. The size and timing of those error signals determines whether learning accelerates or stalls. The Safe Harbor. The first tier is the Safe Harbor, a balanced task the patient can perform successfully with effort and attention. This is not easy, but it is achievable. From a cerebellar standpoint, the Safe Harbor generates meaningful but manageable prediction errors. The cerebellum uses these errors to refine its internal forward model, its running prediction of what sensory feedback should feel like during a given movement. Manto and colleagues describe this process as the cerebellum computing estimates of sensory feedback and updating internal models when prediction errors occur. Clinically, the Safe Harbor also preserves motivational integrity. Research by Marshall Crespo and colleagues, published in Frontiers in Neuroscience in 2017, demonstrated that sustained, overwhelming error suppressed activation in the brain's reward system, reducing motivation and, most importantly, impairing learning. The Safe Harbor prevents that suppression by anchoring the patient in a context of achievable success. Okay, can you close your eyes? Pretty good. Challenge 1. After several minutes on the Safe Harbor surface, the patient is briefly moved to a perturbed or more demanding surface. Challenge level 1. This is significantly harder. Errors increase. The movement system is pushed outside its current predictive capacity. This structure mirrors what Marshall Crespo and colleagues found to be most effective in their robotic gait training study. Brief, unexpected perturbations that push subjects away from their comfort zone increased attention and muscle activation without the sustained demoralization associated with prolonged error amplification. Subjects trained with random disturbing forces showed better learning transfer than those trained with errors continuously amplified. The brief exposure to Challenge 1 generates a rich error signal that the cerebellum can use. Immediately returning to the Safe Harbor then provides the recalibration window, a period of lower noise input during which the cerebellum can consolidate the updated internal model against clean proprioceptive and vestibular feedback. Now try and close your eyes.
That's so funny.
Okay, you can open your eyes there. And see. The impossible goal. The third tier, the impossible goal, is introduced early, even before the patient can achieve it. In this protocol, that might be a Bosu ball with eyes closed, or a highly unstable surface combined with a cognitive task. The impossible goal serves 2 functions simultaneously. First, it generates explicit motor awareness. The patient consciously experiences what the target movement demands, even while failing to achieve it. Marshall Crespo and colleagues found that explicit motor learning, where subjects actively searched for the correct movement pattern, transferred significantly better to novel tasks than implicit learning driven purely by error suppression. Brief, framed exposure to the impossible goal feeds that explicit awareness. Second, because the exposure is short and immediately followed by a return to safe harbor, the reward system suppression that Marshall Crespo observed with prolonged error amplification never accumulates. The impossibility is experienced as a glimpse of the next horizon rather than a failure state.
Close your eyes for a second.
It's
Okay.
hard to find it.
The living scaffold. What distinguishes this protocol from simple interval training is that the tier boundaries are not fixed, they move. As balance improves, the safe harbor task begins to feel routine. That sense of boredom is a clinically meaningful signal. It indicates that the internal model for that task has been consolidated, that prediction errors have dropped below the threshold needed to drive further cerebellar adaptation. Manto and colleagues noted that as motor tasks become automated, cerebellar activation decreases and control progressively transfers towards subcortical and striatal systems. Boredom is the patient's subjective experience of that neuroimaging finding. When boredom arrives, challenge 1 becomes the new safe harbor. Eyes closed, previously a challenge, becomes the new intermediate tier, and the Bosu ball, once impossible, becomes the new horizon to reach toward. The patient is never stuck. The scaffold rolls forward continuously, always maintaining the 3-tier structure: achievable anchor, meaningful perturbation, aspirational horizon. Why this works. The protocol implicitly solves a problem that formal motor learning research has struggled with directly. Marshall Crespo found that neither pure guidance nor sustained error amplification produced optimal learning across all skill levels. Guidance reduced effort and attention. Sustained amplification suppressed motivation. What worked best was a calibrated perturbation within a success context, which is precisely the architecture this 3-tier rolling protocol provides. From the cerebellar perspective described by Manto, the protocol continuously supplies the prediction error gradient the cerebellum requires to drive plasticity, while protecting the motivational and attentional systems that make learning possible in the first place. What you are watching in these clips is not simply balanced training. It is a structured conversation between the clinician, the patient, and the patient's cerebellum, conducted in the language of calibrated error.
All right, so that's not a big problem for you anymore either.
That concludes our discussion for today. I hope you found this information valuable for your clinical practice. Thank you for your attention, and I wish you continued success in your work with patients. I hope to see you again at a future lecture.